to talk about your heart tonight with Dr. Joe Brennan and Dr. Jude Clancy. Thanks so much for coming on. There's a lot of myths about heart. It's called the silent killer. Why is it called that? Take it, Dr. Brennan.
Well, a lot of individuals don't recognize symptoms that may be apparent to physicians. Fatigue, vaguely described chest discomfort, not putting a combination of a number of risk factors together.
Just aches and pains.
Aches and pains. I just don't feel good. I feel a little tired. I'm not able to perform what I want to do. And they don't couple that with the risk factors that are prevalent. Their hypertension, their high cholesterol, their diabetes, the relatively sedentary lifestyle.
What does tightness of the chest feel like? How does somebody describe that? I mean, all of us have aches and pains. You want to take that? What does it feel like that means your heart's in trouble?
So, I mean, there are a couple of classic symptoms that people describe. One is that they feel like a squeezing. It's not so much of a sharp pain or stabbing pain as it is a pressure. An elephant standing on your chest, or just this band of tightness around your chest, the squeezing. That's one of the more classic signs that we pay attention to, although, you know, chest pain can manifest in so many different
So what's
ways.
not a classic sign? Let's say your numbers are great. You look the picture of health, but it's that heredity thing. So how do you know that you have a heart issue?
I mean, sometimes it's, you know, fairly obvious. For instance, I mean, if you go out and you shovel and, you know, you've come back in, or you do some exercise and all of a sudden your chest is sore, but it hurts to move or it hurts to press, you know, and the pain is right there and you can palpate it. Those are what we would call musculoskeletal type pains. But, you know, there's as Joe will mention too, there's a vast spectrum between that and the classic angina that we describe of squeezing, and so that's where it gets hard. You know, there's a lot of diagnostic and kind of, you know, experience that goes with trying to tease out what's important and what isn't important in terms of pain.
Now the two of you work a lot together. We'll call you the plumber, we'll call you the electrician. You're at Yale. You work hand in hand lots of years. How has caring for the heart changed over the years? You know, when I used to hear open heart surgery and they're really going inside. There's a lot of different things now.
Oh, technology has evolved so much, particularly over the past 10 to 20 years. What were usually open heart procedures have now become sort of the purview of the interventional cardiologists, the plumbers, you know, where they can go in and insert balloons and stents that have medicated coverings that limit the re-narrowing rate associated with them. The technology has evolved so that now we can do things that we didn't even think about years ago. Valve surgery, which used to be very much a mainstay of surgeons, is now being done by interventional cardiologists, again, the plumbers, where they can go in through the groin and insert artificial valves. It's incredible how much it's changed.
So you're the plumber. I love these terminologies. What does the electrical guy do? Dr. Clancy, what are you doing as you two work together?
Yeah, so we do various different things. One is that we can put pacemakers in people who are passing out or may have slow heart rhythms. The other thing we put in is what's called a defibrillator, which is a small unit that's implantable that if someone had a dangerous fast heart rhythm would charge up and shock the heart and save the person's life, having like paramedics. Another big part of what we do is ablation procedures, where we go inside the heart from people that are having symptomatic fast heart rhythms, and we map out where the extra short circuit's coming from, and we heat that up and get rid of it.
At what point in our lives should everybody have a cardiologist? Do you wait to that magic 50 number, 60 number? You know, as we all grow up, we all think that cardiology, unless you have issues as a child or what have you, that's a later on in life thing. Are we messing that up, do you think? Should we see cardiologists sooner than we do, a lot of us?
So we as cardiologists would probably say yes.
Sure, that's the correct answer, yeah.
Everyone should. That being said, those with risk factors probably do need to begin seeing cardiologists earlier in life. And probably the biggest, most prevalent risk factor, and probably the most important, is those individuals with diabetes. We all know that throughout this country, diabetes is an epidemic. It's not only in this country, but in others. And diabetics, in and of themselves, have a much greater likelihood and prevalence of coronary artery disease. Those that have risk factors, as I've said before, you know, the hypertensive, the high cholesterol, the very striking family history, particularly at an early age in their parents or close relatives, they should see cardiologists.
So 30, 40 years old, something like that? Yeah. You all, I have also heard of folks that say everybody should be on a statin. What do you say to that? That, you know, none of us should have cholesterol. What do you say to that?
So I've heard some cardiologists say it should be like fluoride and just put in the water.
Right.
That being said, that's probably not a good idea. Some people may have intolerance to those. But those absolutely that have risk factors, we have different goals for lowering cholesterol levels for diabetics versus non-diabetics. For those that have documented coronary artery disease, they have numbers that we have to try to reach. One way to reach that is through the use of statins. They are widely used. They're the most widely prescribed drug that we have in this country, and they are very useful in what we do.
But there are side effects. So you can't just go on statins, and the side effects are what?
So, I mean, I think the issue about everyone taking a medication is, you know, the more people that take it that don't benefit from it, the more likely they are to develop side effects from it, because none of the medications we deal with on either side, the electrical or the plumbing, are specific for what we want it to. And so when drugs aren't specific, they target other areas, and that's how you get side effects. So, you know, one of the big problems with statins in terms of people tolerating them, for instance, is some people develop, you know, these real myopathies in the legs. They develop weakness, pain, and it gets to the
Is that
point.
a small fraction of the population that develops that?
It is a small fraction, but it's a significant, you know, it's a significant happening, especially, so let's say I'm 35 and I'm young and healthy, and, you know, I just go randomly on a statin and I develop a myopathy of my legs. I'm going to be very disappointed that I took the statin. So I think, you know, as Joe's saying, we risk, you know, a lot of what we do in medicine is risk stratify people, and we decide, okay, well, the benefit of you taking the medicine far outweighs the risk, so you should take the medicine, whereas someone, you know, who has no risk, then has no benefit, then all you're going to get is risk. And so that's kind of how we decide, based on blood work and risk stratifying, who should have certain medicines and who shouldn't.
Are we seeing more heart disease in this country or less?
More.
More. At a younger age?
Yes.
Why?
One of the reasons we're seeing more heart is obviously diabetes. As I said, that really...
Diet's a mess.
Diet, smoking, actually, the use is diminished, fortunately, but dietary as well as sedentary lifestyle are two of the biggest risk factors for that. So we do see it. We also see it a lot in older individuals. As you can imagine, people are living longer. They're living longer through better medical care, too. So we see it at both ends of the spectrum.
So how many years collectively you've been in practice?
He's been in practice a lot longer.
A lot longer. I knew you were going to say that.
What?
50, 60 years, okay?
Yes.
Somewhere in that ballpark. Over that time, the trends are what? What kind of trends? Younger folks you're treating for heart disease? We just talked about that. What are trends that you're seeing over that amount of time?
I'm seeing more awareness of it, I'll be honest with you. There's a lot of push made by the American Heart Association, the American College of Cardiology regarding public education. So people come in with appropriate questions and concerns. That being said, when we see real young individuals with it, and we do, both of us see an awful lot of young individuals, and particularly when it comes to coronary disease, the vast majority of those are smokers. The vast majority of
We
those
haven't
are smokers.
learned how to stop doing that.
We have not, and unfortunately that's a big deal because that impacts their life dramatically to have a cardiac event at a very young age.
Yeah.
You think about long-term employment, you think about long-term insurability, the need to taking multiple medications over an extended period of time is a big, big, big deal.
Let me ask you about your practices. Do women come in, or you see mostly men, women go, it's an ache and pain, I don't come in. But women have heart disease too, and we don't look at that enough. Do you agree with that?
Yes. So I see a lot of women in my practice. And
after they've had a heart attack?
Usually after. That's correct.
Okay, I guess that's my point.
That's absolutely. So my office predominantly is people after a heart attack and other individuals to see for high blood pressure, high cholesterol. And those individuals, women, as you're aware, and Jude is certainly aware of all that, have atypical symptoms to begin with. Their symptoms may be entirely different than
Okay, let's go over some of those atypical symptoms. What are they?
Jaw discomfort, back discomfort, not the typical pressure, discomfort that individuals feel in the middle of their chest. It may be something as subtle as I'm just a little short-winded. So women do absolutely have different symptoms, and particularly they actually have those when they're in the midst of a heart attack. So the symptoms are not recognized as readily, not only the prodromal symptoms, but the ones that occur with a heart attack.
You agree with that?
Absolutely. I think it is difficult because women tend to present more, what we say, atypical than men in terms of their symptoms. And, you know, I think, you know, there's a growing education and awareness, and certainly programs like yours help. You know, everyone used to think, oh, guys have heart disease and guys drop dead of heart attack. So there's that other, well, it mustn't be my heart because I'm a woman, or it mustn't be your heart because you are a woman, either from family or medical side. So there's a growing awareness that, yes, absolutely, women have significant heart disease.
At a certain age, should all of us have a stress test, and should the dye be shot in so we can actually see if there's a blockage? I mean, we walk around a lot and we don't know we're sick. We feel healthy. So how do we get to that? What's the answer? I mean, insurance, you know, insurance is not going to pay for all of that.
No, they won't.
But how do we better take care of ourselves? I mean, at 50, get a stress test. I mean, I guess every individual is different. So how do we get ahead of a heart attack?
Be aware of symptoms, as Jude has said, and two, treat the risk factors. And as we were bantering around a little bit earlier, the one thing you can't change is obviously you can't change your risk factors, you can't change your genes. All of those are modifiable. There have been a number of studies that have looked at whether or not routine stress testing is not indicated but important in sort of picking out individuals that have significant coronary disease. And they have been negative, meaning that the results have suggested routine screening stress tests are not beneficial, even in high-risk groups of individuals,
Really?
Diabetics. And the reason for that is that coronary disease takes forever to develop. And what I mean by that, we all, at young ages, begin to develop atherosclerosis, even in our teens. I know.
Good
As we
news.
sit around here
Right.
with the American
It's
diet
growing,
and so
right.
forth, we all develop atherosclerosis at a young age, begin to. And then it progresses over time. And it takes a significant amount of narrowing of a coronary artery to lead to an abnormality on a stress test. And that significant percentage may be up to 70, 75, 80% narrowed before you even know it's there.
What is a stent? Because stents have changed. How would you describe a stent to somebody who has not had one? They're little, they're coated, they're...
I try and explain it to people. So basically the way I always say it is, you know, when you have coronary artery disease and you have a narrowing of the artery, you have this lumen, or the inner diameter of the artery that's narrowed. And what you try and do is you get across that with a wire, and then you blow open that with a balloon. Now, if you just use the balloon alone, the rate and chance of it re-narrowing again is very high. So what doctors like Dr. Brennan do is they put this, I say it's like a mesh scaffolding that's collapsed at first, but they can expand that, and it holds open the artery at that blockage area to prevent it from narrowing.
Now they last forever now, correct? They used to not last forever?
So to Jude's point, in previous days, when you talk about evolving technology, in previous days, a balloon was all that we had.
And you did them all the time, right?
Did them all the time. And the comment used to be made that you had to have, if you had 200 patients, they were always coming back to you. It was somewhat similar to an annuity. They kept on coming back.
Right.
They really did, because the re-narrowing rate approached 50%. Stents lowered that. Regular stents, the scaffolds that Jude refers to, have initially lowered that to about 25% re-narrowing. And now, with the medicated stents, that is very, very, very tiny. The likelihood of re-narrowing is extremely
And what is a
tiny.
medicated stent?
So the body responds to balloons and stents by creating scar tissue in just the area you don't want it to happen, the artery that you've just intervened upon. And the medicated stents, and they're actually, one of them is an anti-rejection drug used in transplants, and the other one was a chemotherapeutic agent, would prevent the over-aggressive cellular reaction to causing the re-narrowing. So it's something that's been around since, commercially available since 2003, 2004, and has continued to evolve over time.
You hear the term open heart surgery. Are you doing as much open heart where they really go in and open you up, less. You know, when you hear about heart surgery, you think of the worst, that you're really going in and taking people apart and going in there and fixing stuff. We're doing as much of that, less now.
Well, I think as Joe mentioned, you know, because of technology and because of, you know, better and better procedures, we're always infringing on how much a patient needs an invasive procedure versus a less invasive procedure. So, I mean, each year, the amount of procedures that get sent to surgery are decreased to some degree, although they're still important procedures, because we're able to do them through less invasive procedures, like angioplasty and stenting, like the valves.
And you're going up the wrist sometimes instead of the leg if you can, which is interesting. Just in wrapping up here, can we debunk some of the myths that are out there about hearts and what you can do and when you should see a cardiologist? Sure.
So, as I've said, I do think that individuals should see a cardiologist if they have multiple risk factors. Diabetics, and particularly long-standing diabetics, smokers, hypertension, high cholesterol, and any individual that feels as if there's symptoms, there's something they just can't put their finger on. Because as Jude has alluded to, symptoms can be quite atypical. It may be that, hey, I'm really tired, I'm fatigued, I don't know why I can't cut the lawn as I did last year. I go out for my evening walk and I find that I'm struggling. I can't carry those bags anymore because I'm short of breath, or there's an abnormal sensation in the middle of my chest or my back. There's something wrong. Get it looked at and evaluated before something untoward happens.
And should we be shoveling snow at a certain age? Heavy, wet snow. I mean, how many heart attacks do you see when we have a heavy, wet snow in this state?
That's a significant number, and I think it's because, number one, you take people who are in general sedentary and then they go out and they shovel snow, and it's a really...
Because it's task-oriented, right? I'm going to get the whole driveway done.
Job. You don't realize how physically stressful it is, and you underestimate that. I remember one of the older emergency department physicians, when there was a snow, once he took one of the ER guys out on a defibrillator pack and had him start shoveling snow, and his heart rate was 160 after a few shovels. You put that in the cold, you put that in someone who hasn't exercised before. You know, when you go to the gym, they say always seek, you know, guidance from your doctors before you start exercising. So here you're going out and you're doing a maximum exercise without any guidance, and people get into trouble that way.
So every time it snows, a heavy, wet snow, you guys just start cringing because you know what's walking in the door, right?
We do. I saw some report where I guess the last big snowstorm that we had where New York got a couple of feet, which was unexpected. There were 10 deaths related to heart attacks. Other deaths related to trauma, but 10 deaths related to heart attacks.
Right.
By a snowblower.
Well, Dr. Joe Brennan, Dr. Jude Clancy, thanks for coming in and giving us some information that we didn't know already.
Thank you.
Thank you.
When one listen, who is this girl? Spend all night kissing and the bubbles right here. Then who else is missing? Got a little sidetracked if I'm so wishing to find the keys to the door, but it's also a metaphor. Need to keep locked in the grocery store of a mind just to save time.